operationalizing Ontario's patch-for-patch fentanyl return program. My name is Maria Zhang, and I'm a clinician educator jointly between the Centre for Addiction and Mental Health and the Leslie Dan Faculty of Pharmacy at the University of Toronto. With respect to disclosures, I have no current or past relationships with any commercial entities. I have received a speaker's fee from OPA for this learning activity. This program itself has not received any in-kind or financial support from any commercial or other organization. This module's learning objectives include: by the end of this presentation, you will be able to review the legal responsibilities for both physicians and pharmacists when prescribing and dispensing fentanyl patches according to new legislation. You will also be able to describe how to operationalize a patch-for-patch fentanyl return program in your pharmacy. And lastly, examine common concerns or challenges that pharmacy staff may encounter and discuss strategies to overcome them. Certainly, we are in the midst of an opioid crisis. On average, 16 opioid poisonings resulting in hospitalization occur every day in Canada, based on information from the Canadian Institute for Health Information. There has been also an increase in the rate of hospitalizations for opioid poisoning over the past 10 years in Canada, specifically comparing 2007-2008 to 2016-2017. When we look at the rate of hospitalizations due to opioid poisonings over the past 10 years, what's really concerning is that the age group with the fastest growing rate are those between the ages of 15 and 24 years old. When looking at the hospitalizations for opioid poisonings in Canada, 31% occurred as a result of self-inflicted harm, which includes suicides. When looking at the data specifically in seniors, more than half of the opioid poisonings in the past year that occurred were accidental. 31% were intentional and 17% were of unknown reason. If we focus specifically in Ontario, we see that the number of emergency department visits, outlined in purple, the hospitalizations, outlined in yellow, and the number of deaths, outlined in green, have risen dramatically over the past decade, but particularly in the past 3 years. When looking at the absolute number of deaths over the past 13 years or so, we can see the relative breakdown of which types of opioids were present at the point of death. There has been a shift from morphine being dominant in 2003 into the end of 2004, which was then taken over by oxycodone, and now we see that fentanyl is being most frequently identified as the opioid or an opioid that is present at death. This is seen in the blue line with a sharp increase, particularly in 2015 to present. Not far behind, though, is hydromorphone, which has experienced a steady increase as well. So what are we doing on the national level? Well, Canada has a 4-pillar strategy to respond to the opioid crisis. Under the pillar of prevention is the strategy to decrease or prevent problematic drug use, to improve prescribing practices, and to better inform Canadians about the risks of opioids. With respect to treatment, there's funding to support innovative approaches to treatment, better access for rural and communities that are remote, including First Nations communities, improving access to medication-assisted treatments for use disorder, including methadone and buprenorphine, and also improving treatment options for pain management as well. With respect to harm reduction, the government is supporting a range of tools and measures for individuals and communities. We're also establishing better access to naloxone across Canada, and also establishing supervised consumption sites. Also within harm reduction is timely access to drug analyses, which will be shared between partners. Also within harm reduction is legislation to protect individuals who seek emergency assistance for opioid overdose. This includes a Good Samaritan Act, which came into law in May 2017, which provides some protections for people who are calling in an opioid overdose to 911. With regards to enforcement, the idea is to support education and training for law enforcement, and to collect, assess, and share information with law enforcement agencies not only domestically but internationally as well. And all of this is supported by a strong evidence base to better identify trends and best practices. With respect to what Ontario is doing, Ontario has implemented a variety of different strategies which have had variable outcomes. One is the delisting of high-strength, long-acting opioids from the Ontario Drug Benefit Formulary in January 2017. Another initiative is the Ontario Naloxone Program for pharmacies, where in June 2016, pharmacies are being reimbursed for take-home naloxone kit provision, along with take-home naloxone kit education and opioid overdose education in general. As of March 2018, the Ontario Naloxone Program for pharmacies not only includes injectable take-home naloxone kits, but also intranasal take-home naloxone kits, which can be provided to individuals with or without an OHIP card. One of our earlier initiatives actually came about in 2016. The regulations took effect specifically in October 2016, where Bill 33 was an act that was introduced to reduce the abuse of fentanyl patches in particular and other controlled substance patches. If we take a closer look at Bill 33, it outlines the legislative requirements for both prescribers and pharmacists, also known as dispensers within the legislation. With regards to prescribers, who may be actually nurse practitioners or physicians, a prescriber who prescribes a fentanyl patch is mandated by law to record on the prescription the name and location of the pharmacy at which the patient or their representative will be filling the prescription. They will notify the pharmacy about the prescription via telephone or faxing of the prescription to the pharmacy, and prescribers are also mandated by law to comply with any other requirements provided in the regulations. As we go through this presentation, more of these will become apparent. For prescribers, when writing the first prescription for fentanyl, they must note first prescription on the prescription itself. The definition of first prescription is if that prescriber has not previously prescribed a fentanyl patch for that patient, and the prescriber is reasonably satisfied that the patient has not received or obtained a prescription for fentanyl from any other prescriber. While the next couple of points are not mandated by law, supplemental guidance has been provided by the College of Physicians and Surgeons of Ontario and the Ontario College of Pharmacists for both physicians and pharmacists. For physicians, this includes clear communication with patients, whereby they should ensure that patients understand the importance of keeping track of every patch that's dispensed to them, whether or not it's used, as failing to do so may result in stolen or lost patches. And if they choose or fail to return all used patches to the pharmacy, this may result in the pharmacist withholding new patches. Supplemental guidance for physicians also highlight the importance that patients have the right to choose which pharmacy will fill their fentanyl prescription. Additional supplemental guidance for physicians include guidance for physicians to collaborate professionally with pharmacists, as a patch-for-patch program really requires both professions to work in concert with each other to ensure that patches are not only prescribed safely, but also dispensed, stored, and returned to the pharmacy in a safe manner. Physicians are instructed to, if they provide fentanyl patches, that they must respond in a timely and professional manner when they are contacted by a pharmacist to either confirm the validity of a prescription, to raise questions or concerns regarding the patches that have not been returned, or where used patches have not yet been returned, to seek advice to what the next best steps would be. with regards to whether or not to dispense the new patches, based on the patient's specific circumstances. If we look at the legislative requirements for pharmacists, otherwise known as dispensers in the legislation, are required to confirm that the name and location of the pharmacy on the prescription by the prescriber is actually the one that's actually filling the prescription. The pharmacy also should have been notified by the prescriber of the prescription before any patches are dispensed. Unless it's a first-time prescription, dispensers must also dispense fentanyl in exchange for used patches provided by the patient or his or her authorized representative. So let's apply some of our knowledge. JL is a new patient at your pharmacy. He's 56 years old and has been diagnosed with severe chronic cancer-related pain that is responsive to opioids. He was initiated on a fentanyl 25 mg per hour patch, and you provided 5 patches for him just over 2 weeks ago. He returns to your pharmacy today, 15 days later, with 1 less patch than you had dispensed. How would you proceed? Would you A, ask him why there's 1 patch missing? B, report the patient to the police due to risk of diversion? C, notify the prescriber of the missing patch? Or D, dispense the next set of patches? So for this scenario, for first-time fentanyl prescriptions, you should actually expect to see 1 less patch on the paper tool, as it should be on the patient's body. One reoccurring theme in this module will be the importance of documentation. You need to document your observations regardless of what the next steps will be, and justifications as to why you chose that next course of action. I would also suggest documenting where the patch is on the patient at that period in time. If possible, you should confirm that the patient is actually wearing the patch and include that in your documentation to justify the 1 missing patch. Also within the legislative requirements for pharmacists is the importance of examining, documenting return patches and storing them in a secure location prior to proper destruction. Let's focus on the examination and documentation of return patches. So now that you've accounted for all of JL's patches, including the one that was on his body, and documented this, notice that the patches that he's returning are quite yellow and discolored. What are your next steps? Would you A, document your observations and dispense the next set of patches to JL? Document your observations and tell JL that you cannot give him the next set of patches because the current ones that he has returned are quite discolored? Or C, document your observations and give the next set of patches to JL for now. After he has left the pharmacy, you would then notify the police for suspected tampering and diversion. When assessing fentanyl patches that are used, there are some things to keep in mind. Used fentanyl patches are totally smooth, they should be non-sticky on both sides, and they may be a bit yellow, white, or brownish because of skin secretions. The back foil may appear dinged, but the fentanyl patches should overall be free of cuts and any needle holes and should not appear dried out. If there are back imprints on the actual patches, they should still be remaining after the medication has been used. Over the next couple of slides, we will look at samples of what unused patches of fentanyl look like. This may be particularly useful for pharmacists who have never seen what an unused patch looks like. You can look up the drug in the ECPS or contact the manufacturer for a guidance document, as we have done here. When looking at unused or Gesic patches, they are rectangular in shape, transparent and frosted in appearance. They are colorless and have rounded corners. They are, again, free of cuts and needle holes and do not appear to be dried out. If we're looking at the imprints, you can see that the Gesic mat is on the actual patch itself. It includes the strength as documented in micrograms per hour, as mcg per hour, and it also says fentanyl transdermal. You can also see that depending on the strength of the fentanyl patch, the color of the text on the imprint is going to look a little bit different as well. Checking for this is going to be useful in assessing whether or not the patches that are being returned to the pharmacy could be counterfeit patches. When looking at Teva patches, we see that again they are transparent, rectangular, and colorless. You can see that they do not appear to be dried out and are free of cuts and needle holes. For Teva patches, it simply indicates fentanyl in dark font, and also it has a strength, but instead of mcg per hour, as noted in the Duragesic patches, this is microgram, as indicated by the Latin symbol for microgram. You will also note that the different patches of different strengths are of different sizes as well. If we look at Myelin patches, we see that, again, they're rectangular, transparent, colorless, with rounded corners that are free of cuts and needle holes and do not appear to be dried out. Interestingly, for Myelin, if you want to get this information from the manufacturer, they will also tell you the size of each fentanyl patch. And again, this can be useful when assessing whether or not the patch, it could be fentanyl counterfeit patch. The back of the patches are imprinted with Myelin, fentanyl, and strength. And again, you can see here, it's documented in mcg per hour instead of the Latin symbol. If we looked at the PMS patches, similar characteristics to the other patches, but you can see that the labeling or the imprint is a bit different depending on which one you're looking at, and the strength is documented in mcg per hour. When looking at unused Apotex patches, they have a similar shape in that they're rectangular with opaque corners, and if they're unused, they actually have that tan backing, but if they're used, they're not going to have that backing. With regards to the actual imprint, it indicates that they're fentanyl patches as well, and the strength is in mcg per hour. The Ontario law enforcement have released pictures of counterfeit patches that have been seized by their police officers. You can see that some tampered or counterfeit patches may not appear to be perfectly rectangular. Their corners may be less sharp or less rounded, depending on what the benchmark is. There may be cuts or needle holes present to indicate some form of tampering with the medication, and there could be crinkled or folded patches, which could be evidence of chewing, squeezing of the matrix. If they're counterfeit patches, they may be missing the patch imprint, or it might look a bit different than what you would expect based on the manufacturer's representation of what unused patches look like. The print may also be quite faint or quite blurry, and again, these are indicators that this might be a counterfeit patch. At the same time, you can quickly see that the counterfeit patches are quite realistic and close to the manufacturer version. So therefore, certainly our pharmacists can do their best job possible in documenting whether or not they think that the patches returned have been tampered with or are counterfeit, but certainly the counterfeits are becoming better with time and may be able to evade detection by pharmacists. The Ontario College of Pharmacists does provide guidance on fake fentanyl patches, such that pharmacy professionals are directed to use their clinical judgment and awareness of the product to examine the returned patches for potential tampering and verify that they are legitimate. If you do have concerns that there's criminal activity, for example, that counterfeiting of patches has occurred, you should notify the police. The Ontario College of Pharmacists indicate that pharmacists should be encouraged to collaborate with the prescriber and alert the prescriber as well to any concerns they have about the patient misusing the medication. In the Supplemental Guidance for Pharmacists Ontario College of Pharmacists highlight that notification of police is a balancing act between the obligation to protect the patient privacy and the obligation to report a criminal offense. Notification should only be undertaken where the pharmacist has concerns that there's counterfeit or misuse or tampering has occurred, or that there's a pattern of returning 0 patches or fewer than prescribed, which may indicate potential diversion. The Ontario College of Pharmacists does have a fact sheet labeled Identifying Forgeries and Fraudulent Prescriptions that will be useful to pharmacists who are facing this kind of situation. With regards to legislative requirements, pharmacists are not only obligated to examine and document the returned patches from patients, but also they need to store them in a secure location prior to proper destruction. This process is outlined by OCP's fact sheet on destruction of narcotics, controlled drugs, and targeted substances. In summary, drugs that are returned by the public should be kept in a safe location before they are destroyed. The importance of safe handling and destruction of fentanyl cannot be understated. In this analysis of 9 patients who had a 3-day application of a fentanyl patch to their body, a radioimmunoassay revealed that after this 3-day application of fentanyl patch, up to 84.4% of the original contents of that patch still remained. This represents up to 4 times the lethal dose of fentanyl. So this is particularly relevant for pharmacy assistants or pharmacy technicians or pharmacists who are taking back used fentanyl patches, that they should have gloves on, in particular when handling this, or to highlight for patients that they should bring back their fentanyl patches on a piece of paper in a Ziploc bag for their safety and the safety of your pharmacy team. In the instance where pharmacists receive a prescription for fentanyl patches but does not collect all of the patient's used patches, or collects fewer patches than the quantity to be dispensed under the prescription, pharmacists are mandated by law to use your professional judgment to dispense an appropriate number of patches based on an assessment of the patient, including an assessment of the patient's circumstances and their medical condition. We are also required to notify the prescribing physician of the number of used patches that were collected, as well as the number of new patches that were dispensed, if any. Pharmacists are supported in making decisions based on their clinical judgment, as demonstrated in this communication to physicians, where the supplemental guidance highlights that in cases where patients fail to return used patches, the law permits the pharmacist to use their professional judgment to dispense an appropriate number of new patches based on the specific circumstances of the patient. Again, it highlights for physicians that pharmacists will notify them that the used patches were not returned and the number of new patches that were dispensed, if any, actually end up being dispensed. Exceptions to the legislation include when pharmacists receive a prescription that has been authorized by a prescriber from outside Ontario and the prescription is verified by the dispenser. Thereby, the fentanyl patch-for-patch program does not need to be enacted in its fulsomeness, or in a situation where a pharmacy is listed on the prescription and the authenticity of the prescription is verified by the dispenser, and no fentanyl patches were dispensed by that other pharmacy. Another example of where there can be exceptions to the fentanyl patch-for-patch program is when pharmacists are dispensing to a resident of a long-term care home, a patient who is confined to a correctional facility, or a patient in a hospital under the following circumstances, where the facility has a written policy establishing a medication management system for the collection and administration of the fentanyl patch, and the dispenser has a copy of that policy. At the Center for Addiction and Mental Health, we have a policy outlining the procedures associated with handling patients' used fentanyl patches. This may be in scenarios where patients have a fentanyl patch on them or a set of used fentanyl patches, and they're admitted to the emergency department or directly from the community setting, and they actually bring these used patches in. In occasions where this occurs, the used fentanyl patches are sent to our inpatient pharmacy for destruction, where we will destroy the contents of the fentanyl patches and document the quantity and date of destruction. The inpatient pharmacy staff at CAMH will also verbally communicate and issue a written confirmation letter stating the quantity destroyed to both the patient and the community pharmacy from which the patient obtained the patches. This confirmation letter is used as a replacement of presenting the actual used patches by the patient to the pharmacy. Just as an aside, in our policy we also outline that staff should use gloves when handling used patches. Just because the patients may affix used patches on a piece of paper doesn't mean that they may not be exposed inadvertently. This is a sample of the documentation that we would fax over to the community pharmacy, where we would highlight the patient's name, their date of birth, the date by which our inpatient pharmacy received and destroyed the number of fentanyl patches, and a witness for the destruction. You can also see here that we provide a similar form of documentation to the patient so that they can provide this to the pharmacy if the pharmacy did not receive it or had forgotten about the faxed communication from CAMH. Again, with regards to supplemental guidance for pharmacists, so things that are not mandated by law, within the event that the patch-for-patch aspect of the program has not been met, the pharmacist will dispense fentanyl patches based on professional judgment and in accordance with the patient's circumstances, history, and the prescriber's instructions. Pharmacists are also guided to communicate effectively with patients, just as the physician. Pharmacists should advise the patient on the requirement to store used patches securely, given the potential harm associated with the residual medication in the used patch. Again, this has been documented to be up to 84% of the original dose may be remaining after a 3-day application. Pharmacists are also provided some supplemental guidance on circumstances that may require contingency dispensing. So this could be in the event where a patient reports the theft of one or more fentanyl patches prior to them using it. In this case, the pharmacist will require a police report. If the patient reports that their medications have been lost, specifically fentanyl patches, the pharmacist will evaluate the circumstances and the history of the patient and whether there is a demonstrated pattern of theft or loss. Another contingency dispensing situation may be where a patient requires more than the usual number of fentanyl patches due to planned travel. In this case, the patient should provide evidence of the dates for travel. This can include a flight itinerary or a plane ticket. With regards to documentation, the Ontario College of Pharmacists does provide supplemental guidance on documenting. This is essentially in line with the requirements established by the Drug and Pharmacies Regulation Act and OCP guidelines as well. Pharmacists are also provided some supplemental guidance on circumstances that may require contingency dispensing. So this could be in the event where a patient reports the theft of one or more fentanyl patches prior to them using it. In this case, the pharmacist will require a police report. If the patient reports that their medications have been lost, specifically fentanyl patches, the pharmacist will evaluate the circumstances and the history of the patient and whether there is a demonstrated pattern of theft or loss. Another contingency dispensing situation may be where a patient requires more than the usual number of fentanyl patches due to planned travel. In this case, the patient should provide evidence of the dates for travel. This can include a flight itinerary or a plane ticket. With regards to documentation, the Ontario College of Pharmacists does provide supplemental guidance on documenting. This is essentially in line with the requirements established by the Drug and Pharmacies Regulation Act and OCP guidelines as well. So when operationalizing the fentanyl patch-for-patch program in your pharmacy, you should refer to the Ontario College of Pharmacists guidance document on executing this program and consult their practice consultants wherever there is need for them. Also, as pharmacists, we need to monitor for trends and document this. So is the client consistently bringing back less patches than expected? And what is the quality of the patches that are returned? Do they look dried out? Are there holes in them? This could be evidence that the patient has been tampering with the medication. Wherever possible, as I mentioned previously, observe and document whether or not the client has a fentanyl patch on their body. This is important because not only is this useful for the first fentanyl patch prescription, but also for all subsequent fentanyl patch prescriptions and dispensing as well, because this confirms whether or not the patient's actually using the fentanyl patch. However, if the patient continuously refuses or is unable to show you an applied patch, this may be an indicator that there could be diversion occurring. Also, at the same time, we should not force anyone to apply a patch on in front of you, just because if the patient has been diverting the fentanyl and we force them to apply a medication to which they have very low tolerance to, they're going to be at very high risk of opioid overdose. For pharmacists, we also have a duty to communicate with our colleagues, specifically prescribers, which may include physicians or nurse practitioners who've completed the appropriate training and have been registered to be able to prescribe controlled substances, regarding both the fentanyl patch-for-patch program, about the returns of the patient and their fentanyl patches, about the quality of the patches themselves, and also any observations you make about the effectiveness or safety issues related to the fentanyl patch. This could be an increase or no change or worsening of function with the fentanyl patch, or perhaps there's concomitant other medications prescribed with fentanyl that increase the patient's risk of opioid overdose. Other universal precautions for opioids include limiting quantities, and this can be for fentanyl patches or for oral opioids such as hydromorphone or oxycodone. Especially for acute pain episodes, pharmacists should really think about whether or not the quantities make sense. If we expect the acute pain to go away within 2 to 3 days, it doesn't make sense to actually dispense 5, 10, or 30 days worth of this medication. Also, thinking about patients who are on chronic opioid therapy, does the patient require or could they benefit from shortening the dispensing interval so that they come to the pharmacy instead of every 90 days, perhaps every 60 days or every 30 days, so that we can improve our monitoring with the patients? We also need to think about storage of medications, whether it's fentanyl patches or whether it's oral opioids. This includes whether or not the patient is able to put the medication in a safe place out of reach of strangers, other members of their family, and or children. and also especially if children are within the household, is there child-resistant packaging associated with all of the opioids? Lastly, whether or not the prescription opioids are dispensed from your specific pharmacy or not, all pharmacies should have a policy where they collect unused opioids as a public health safety initiative. Also, pharmacists can provide training to patients who are on opioids and or street drugs on naloxone administration. Remember, patients who are being exposed to opioids, whether it's through prescription opioids, whether it's through heroin, or through street drugs that are typically more stimulant-like, such as cocaine, but contaminated with opioids, all of these individuals qualify for a take-home naloxone kit because they are all at risk of opioid overdose and opioid-related mortality. For patients who are on opioids, we should also look at which other medications they're on, specifically if they're on other CNS depressants, such as benzodiazepines, as this significantly increases the risk of death. And lastly, as a universal precaution, pharmacists should follow up on narcotic monitoring system alerts whenever and every time they show up. This is information that currently only pharmacists have access to, so this is information that we must relay to our partners, whether it's nurse practitioners who are prescribing opioids or controlled substances, or for our physician colleagues. Thank you very much for joining us in this module.